Hello everyone, my name is Daniel. I'm a fourth year medical student and I'm the co-founder of USMLE Forum of Pakistan. In this video, we're gonna discuss some high-yield concepts from neurology, and these concepts are repeatedly discussed in your NBMEs, your friends' NBMEs, and these concepts are repeated in the USMLE exam, and they are very high yield for your USMLE exam, right? Especially for step 1. And those who are not preparing for step 1 and who are watching this video, I would suggest them to watch this video till end, because these are the basic principles of neurology we are discussing here. So it's not only beneficial for your USMLE step 1, but also for your medical sciences, right? So we're going to discuss a few segments, and the whole video is divided into few segments. I guess 4 to 5 segments. I designed the video into 4 to 5 segments. So the first segment is about neuroanatomy and neurophysiology. Okay, so let's begin. First of all, let's talk about the concept of blood-brain barrier. Blood-brain barrier is comprised of tight junctions, we all know, and the junctions are between, yes please, endothelial cell, good, astrocyte, and pericyte, right? So this is about the basic concept of blood-brain barrier. So for the rest of your life, you have to remember that the three major things constitute the blood-brain barrier. First of all, endothelial cell, astrocyte root process, and pericyte. Awesome. Second thing we're going to discuss here is about cerebellar lesions. Cerebellar lesions. Okay, so these are, first of all, let me tell you a few things about that. That if the lesion is on the lateral side of cerebellum, it's gonna affect the limb, like coordination. And if it's affecting the medial, and if it is affecting the medial side of our cerebellum, it's gonna affect gait and posture, right? I used to remember the whole concept as, because if you see the cerebellum, so it's just like a band, right? A wide band. So if you see the body, if you see the human body, so now, and in the middle of in the medial side of the human body is the trunk, right? We all know that it's a very basic thing. So even non-medicos knows that the trunk is on the medial side, so of the body, right? So if we talk about cerebellum, any lesion that is affecting the medial side of the cerebellum, it's gonna affect the trunk. Any lesion that's gonna affect the lateral side, because we have limb on the lateral side, so anything that's gonna affect the lateral side of cerebellum is gonna affect the limbs, right? Awesome. Now let's talk about basal ganglia. Basal ganglia have got two circuits: direct pathway and indirect pathway. I know that there are a lot of things going on in the basal ganglia, but I'm giving you two important things, and that are important for the rest of your life. Trust me. Okay, so these are direct pathway that facilitate movements, and the indirect pathway that inhibits movement, right? Awesome. Now let's talk about thalamic nuclei. We got different nuclei in the thalamus, like VPL and VPM, right? So VPL and VPM relay sensory information, and LGN and MGN, lateral geniculate nucleus and medial geniculate nucleus, they processes visual and auditory inputs. The LGN processes visual input, and the MGN processes auditory input. Awesome. Now let's talk about spinal cord tracts. Okay, so in the spinal cord tracts we have dorsal column, which is for fine touch and proprioception, and spinal thalamic tract transmits pain and temperature, right? So we got two pathways, like dorsal column and the spinal thalamic pathway. Awesome. Another thing, cranial nerve nuclei and location. So cranial nerve nuclei and location. So yeah, midbrain consists of the cranial nerve nuclei of cranial nerve 3 and 4, and pons consist of 5 to 8, and the medulla consists of 9 to 12, right? 9 to 12. So if any pathology or any brain lesion that is affecting the medulla, It's gonna affect, cranial nerve number 10 probably as well. And any lesion affecting bones, it's gonna affect cranial nerve number 5 to 8. Awesome. Now let's talk about circle of Willis. What is circle of Willis? We all know very well. And anastomosing ring providing collateral blood flow to the brain. Awesome. Now, what's the CSF flow pathway? Okay. Now the CSF flows from lateral ventricle. You got lateral ventricles here. From the lateral ventricles to the foramen of Monro, and from the foramen of Monro to the third ventricle, the middle one, and from the cerebral aqueduct to the fourth ventricle. That the fourth ventricle is in your brainstem, right? And from the fourth ventricle to the subarachnoid space, we all know very well. Remember this is very important for hydrocephalus, because if you know how to connect these things, so you're gonna understand the concept of of hydrocephalus, direct and indirect hydrocephalus. Awesome. Now the neurotransmitter systems. We got dopamine in the substantia nigra. We got, this is very important, literally, trust me, it is very important. It is asked multiple times. NBMEs assess this concept multiple times, honestly. So we got dopamine in the substantia nigra. We got serotonin in the raphe nucleus. We got norepinephrine in the locus ceruleus, and we got acetylcholine in the basal nucleus of my nerd, I guess, if I am pronouncing it correct or not, I don't know, but it is spelled as MEYNERT. Awesome. Now, myelin versus Schwann cells. Okay, oligodendrocytes myelinates CNS axons. Schwann cells myelinates PNS axons. A very important concept. Do you know that optic nerve is a member of CNS or PNS? Yes, it's a member of CNS. And all the diseases that are affecting CNS, especially multiple sclerosis, it affects CNS, central nervous system, rather than your peripheral nervous system. So that's why multiple sclerosis is a disease that affects your CNS, and that's why it's also affect optic nerve, because as I've told you that optic nerve is also a part of your CNS, right? And the reason why we know about the optic nerve thing, because previously scientists discovered that the optic nerve is also myelinated by your oligodendrocytes, while the rest of your cranial nerves are myelinated by Schwann cells. Awesome. Now let's move towards our segment 2. That's very important, honestly. These are things that NBME loves to test, honestly. NBME assess these things multiple times, 1,000 times. I don't know from how long USMLEs have been conducted, but NBME assesses these things multiple times, honestly. So first of all, let's talk about Parkinson's disease. What is Parkinson's disease? What happens in that? Degeneration of dopaminergic neuron in the substantia nigra compacta. Remember this; it's very important. Awesome. Huntington disease. It's an autosomal disease in which you have multiple CAG repeats, right, in your DNA, and that leads to caudate atrophy. Yeah, as far as I remember, it leads to caudate atrophy, and I'm damn sure I'm correct. Okay, now amyotrophic sclerosis, which is also acronated as ALS. So it is a combined upper motor neuron and lower motor neuron pathology. Okay, so you got upper motor neuron lesion, LMN neuron lesion. But I have to tell you a very important thing regarding ALS. What's that? Stephen Hawking's got ALS. We all know that. It's not that important for your USMLE. Yeah. Important thing regarding ALS is that the reason why ALS is very lethal, because it leads to respiratory depression lately, and in most of the patient with ALS, ALS undergo intubation, respiratory intubation. But it's a very poor prognosis, and it's a very fatal disease, honestly. Okay, now multiple sclerosis. It's a very interesting disease, and it's autoimmune demyelination in the CNS and presents with optic neuritis, because as I've told you that it affects optic nerve, and it also causes internuclear ophthalmoplegia. Yeah. Next, Guillain-Barré syndrome, GBS. It's an acute demyelinating polyneuropathy, and that is ascending polyneuropathy, right? Means your legs will go first, then your upper body. Awesome. And it's often follows infection, right? Let me tell you one thing. Whenever you are in your wards, and if you suspect GBS, you should take the history regarding previous respiratory or previous GI infection. That's very important. Because most of these things are not known by students, and students skip these things. But USMLE also assess these things multiple times, and let me tell you, if you ever see the question, if a person was having previously respiratory infection or GI infection, and now he's having neurologic symptoms, go always with GBS, literally, trust me. As far as I have known, as far as I have done see NBMEs, as far as I have seen NBMEs, go for your GBS, right? If you see infection and then you see some neurologic symptoms. Another important thing regarding GBS I want to share that just like ALS, GBS can also cause respiratory depression, right? And since it's causing respiratory depression, so again it's very fatal, and again a very poor prognosis. Okay, myasthenia gravis. And again, how do you treat GBS? As far as I remember, we do some plasmapheresis or we give some antibodies, monoclonal antibodies. I would say that that's something you should look at your own if I'm wrong. So you look at your own. Anyways. Okay, so myasthenia gravis. In myasthenia gravis, there are autoantibodies against acetylcholine receptors, and that causes muscle weakness with use. Remember, that's how you diagnose myasthenia gravis. You ask the patient, oh my god, whether you are having a muscular weakness after using muscles, does it worsen with the usage of muscle? The myopathy, the muscle weakness, you ask about that. Does the muscle weakness worsen with movement? So if they say yes, boom, it's myasthenia gravis. Now, Lambert-Eaton syndrome, it's due to antibodies, autoantibodies against presynaptic calcium channels. Like if you remember that you got an axon terminal, it got some calcium channels, and those calcium channels are responsible because those calcium channels are responsible for the movement of synaptic vesicle, right? But if those calcium channels are not and if those calcium channels are blocked, or if those calcium channels are injured somehow by the autoantibodies, so those calcium channels will not work and synaptic vesicle will not move, and if the synaptic vesicle is not moving, then the neurotransmitter won't be released in the synaptic cleft, and again no neurotransmitter will be transmitted, and that leads to muscle weakness. Okay, but remember that in Lambert-Eaton syndrome, the strength improve with use. I can't go into the detail of that because we don't have much time, but just you have to remember for the rest of your life that in the myasthenia gravis, muscle weakness worsens with use. In Lambert-Eaton syndrome, muscle weakness improves with use. That's it. Nothing more, nothing less than that. Now, Alzheimer's disease, beta amyloid plaques and neurofibrillary tangles that affect hippocampus early, right? Earlier. Again, it's very important to know. Okay. Now, vascular dementia, it's a stepwise. Remember. Let me tell you something very interesting. Vascular dementia, you know that when you see the scenario of the dementia, you might be confused. Either it is frontotemporal lobe dementia, FTD, whether it is vascular dementia, or whether it is Alzheimer's disease. Let me tell you one thing. That if the question is about vascular dementia, patient 90% patient have the history of stroke. 90%. Sometimes patients don't have history of stroke. How are you gonna diagnose them? Then you will see that there is a stepwise decline in the neurocognitive function. If there is stepwise decline, boom, go for your vascular dementia. Of course, NBMEs are not gonna say, oh my god, your patient has having stepwise decline. You have to comprehend this from the history and from the stem of the question. That if the question is explaining you the things in a way that it is exhibiting some stepwise decline in the neurocognitive function, then you have to think about vascular dementia. Frontotemporal dementia, how does it appear? It appears as very simple. The patient might have history of disinhibition. It's very important. And there's some non-acceptable sexual behaviors, and disinhibition is very common. The patient can pass comments on anyone easily, right? So that's the disinhibition concept in the frontotemporal lobe dementia. Remember for the rest of your life that if the frontal lobe is impaired, patient will show there will be a drastic change in the behavior of the patient, right? Patient won't be polite anymore. That's the key buzzword, telling you about FTD. Awesome. Now, normal pressure hydrocephalus, that's very important. And in this NPH, we have triad of urinary incontinence, we have gait disturbance, and we have dementia. This is very simple. Of course, again, NBM is not gonna say, oh my god, your patient is having urinary incontinence, he's having dementia, he's having gait disturbance. Of course, you have to evaluate these things from the stem. Awesome. Now, let's move towards our segment 3. That's very important, honestly, trust me. Not for your step 1 only. It is high yield for step 1, but it is also important for your neurology concepts. Awesome. So, middle cerebral artery stroke. How does it present? Yeah, contralateral face and arm weakness. Aphasia if the dominant hemisphere is damaged. I remember that when I was in my medicine ward, I encountered a patient having middle cerebral artery stroke, and the PG who was on the ground has asked me that how does MCS stroke appears. So from that time I still remember that it affects the arm, face and arm. That's it. There's nothing more, nothing less than that. That's a huge thing about MCS stroke. You have to remember and you have to keep this thing in the back of your mind. Anterior cerebral artery stroke, it causes contralateral leg weakness and sensory loss. Posterior cerebral artery stroke, it causes contralateral homonymous hemianospia with macular sparring. That's a very tough concept to tell you without any diagram. Later on, when I'm gonna conducting the things over some projector, so then I'll tell you about the hemianospia thing. Or if you have any difficulty in understanding the concept, you just can text me. You can comment on this page, on this channel. I'm gonna help you with that because I have made something very easy to remember, provided if I have any image to show you. So that's it about PCS stroke. But if you again have any difficulty in remembering the anospia things, just contact me. Okay, lacunar infarcts, small vessels stroke affecting deep brain structures and affected by hypertension. I have also seen the case of lacunar infarct with my eyes, honestly, because when I was in my medicine ward, I forgot the number of ward. I guess it was M6 or M7, but I have seen that there was a patient who was non-compliant with her antihypertensive meds due to some financial reasons. So she had a lacunar infarct. So the case was very devastating to see honestly. So that's a very bad thing for the patient. So remember lacunar, but what you have to remember that lacunar infarcts affect the deep brain structures, right? Because if you think about the lacunae, so lacunae are something embedded deep into the brain tissue. So that's it. Okay, now epidural hematoma. It is a lens-shaped hemorrhage. You are studying this from your second year of medical school, that epidural hematoma is a lens-shaped hemorrhage often due to middle cerebral artery rupture. Subdural hematoma, It's due to it's a crescent shape thing on the side on the CT scan, right? And it's due to tearing of bridging veins. So subdural hema most likely occurs in the elderly people, but epidural hematoma most likely occurs after a trauma, post trauma. Awesome. Subarachnoid hemorrhage. You know that how does the patient present? Worst headache of life. They say, oh my god, I'm no, of course not every patient gonna say that the same thing, but the headache is very severe, and it's due to rupture of berry aneurysm, right? So berry aneurysm are embedded between arachnoid matter and pia matter, right? So here is your pia, here is your arachnoid, here is the dura. So this is your arachnoid, this is your pia, and these are the berry aneurysms over here. Awesome. Intracerebral hemorrhage, they are again bleeding within the brain, parenchyma, commonly due to hypertension. Awesome. Cerebral amyloid angiopathy, it is beta amyloid deposition in the vessel walls, and it appears as lobar hemorrhages elderly. Remember what you have to remember: intracerebral hemorrhage, it's due to some parenchymal vessels. Lobar hemorrhage is due to cerebral amyloid angiopathy. Like blood vessels are affected and they are leaky in this scenario because of deposition of amyloid protein over the blood vessels, right? And that's it. Okay, now transient ischemia attack, it's brief reversible neurologic deficit without infarction, and the patient usually patient a patient recovers very easily. Awesome. Now moving towards our segment 4. Segment 4 is about seizures and epilepsy. Multiple times it is assessed in the NBMEs, so your friends NBMEs kind of love these things to test. Everything in this podcast are high yield. Everything in this podcast is discussed by NBMEs multiple times. So literally I have just skimmed over the NBMEs, and I can't tell you the number of NBMEs. I don't want to tell you, I don't want to be a spoiler for you, but these are the repeated concepts, right? Repeated concepts, trust me. Okay, these are not a spoiler from your NBMEs exam, these are just repeated concepts from NBMEs. Now, absent seizures. What is absent seizure? Absent seizures usually occurs in the child, right? The NBMEs on your exam, always there is always child, and this is just like a brief lapses in consciousness, and on the EEG you will see 3 hertz spikes, right? 3 hertz spikes on the EEG. This is what you see on the EEG, electroencephalogram. Tonic-clonic seizures, these are loss of consciousness without with stiffening and rhythmic activity, right? Myoclonic seizures, these are brief muscle jerks without loss of consciousness. Status epilepticus, this is very important, because status epilepticus, if lasts of course, what is status epilepticus? If it is that seizures are lasting for more than 5 minutes. So in the status epilepticus, since the seizures are lasting for more than 5 minutes, there's a huge risk they're gonna affect your neurological structures, brain structures ultimately, right? So again, bad thing. Awesome. Febrile seizures, these are common in children, of course, and as the name suggests that they are due to seizure fever, right? Febrile means fever, so they are due to fever, right? So if you see a child having high temperature and seizures, what you're gonna do? Just reassure the parents. Just reassure. You don't need to give any medication, literally. But if the febrile seizures are occurring recurrently, then you have to consider medication. But usually on the exam, on the real life, on the real deal, there is no need to treat. There is no need to start the patient with febrile seizures on anti-epileptic meds, right? So just reassure the patient that okay, these are febrile seizures. They will improve with time, or they will improve as the fever goes down. Temperature goes down. Temporal lobe epilepsy often presents with aura, right? Patient might have some feelings, right, that he's gonna have the temporal lobe seizures like tinnitus, like buzzing of ears, and yeah, that's it. And yeah, and they present with automatisms. And if you go for MRI of these patients, you're gonna see temporal sclerosis on MRI. Yeah. Okay, juvenile myoclonic epilepsy, as the name suggests, juvenile, it's seen in kids, and myoclonic jerks upon wakening, and generalized tonic-clonic seizures. Okay. Okay. Now there are few things regarding neuromuscular disorders, and trust me, they are assessed multiple times. I can't tell you the numbers, honestly, because you gonna forget the number. Honestly, trust me. Okay, Duchenne muscular dystrophy. It's an X-linked recessive disease due to absence of dystrophin, and in these patients, you're gonna see a very important sign, which is Gower's sign. What is Gower's sign? That the child may use his upper limb to take a stand, right? So this is the Gower's sign. Also, you will see pseudo hypertrophy of the calf muscles on your legs. So you're gonna see that as well. Becker's muscular dystrophy, it's an X-linked recessive. They're gonna affect female? No, they're gonna affect male, right? X-linked recessive disease and due to defective dystrophin. Okay, remember in Duchenne muscular dystrophy (DMD) we have absence dystrophin, but in the Becker muscular dystrophy we have dysfunctional dystrophin, defective dystrophin, you can say. So it is just like a milder form of Duchenne dystrophy. Now, myotonic dystrophy. It is due to CTG repeats. What happens due to CAG repeats? God, Huntington. Okay, so myotonic dystrophy, it's due to CTG repeats. C for cat, T for TFOP, awesome, and G for gangster. So CTG is due to CTG repeats. Expansion, CTG repeats expansion, and you're gonna see myotonia, you're gonna see cataracts, you're gonna see frontal bleeding in these patients. Awesome. Charcot-Marie Tooth disease, it's usually less assessed on NBMEs. NBMEs don't assess this disease much, but since I've seen this somewhere, not in the NBMEs but somewhere else, that's why I'm mentioning this. It's hereditary, motor, and sensory neuropathy. You're gonna see foot drop, you're gonna see pes cavus. Pes cavus is a foot finding, high arch foot, right? So that's it. Friedreich ataxia, multiple times, assessed multiple times. Okay, so in this you have GAA repeats, expansion, and you got ataxia, you got cardiomyopathy, you got diabetes. Spinal muscle atrophy, degeneration of anterior horn cells, and in your PEDS exam, it appears as floppy baby syndrome. Floppy baby syndrome, that's it. It's because if your anterior motor neuron cells are damaged, you're gonna have lower motor neuron palsy, and lower motor neuron palsy appears as the dysfunction or the loose hands, the loose limbs, right? That's it. Okay, now botulism. It's due to toxin that inhibits acetylcholine release and causes descending paralysis. GBS causes ascending paralysis, it causes descending paralysis. Again, it's also very lethal because ultimately it's gonna lead to respiratory failure. Not only that, it's gonna affect what was these called? Come on, Daniel, you remember? I don't remember the name. Yeah, it's gonna affect your bulbar region. Bulbar region, yeah. So that's why it's gonna lead to some dysphagia as well. Again, descending paralysis, not a good prognosis. Not a good prognosis. Organophosphate poisoning, it inhibits acetylcholine esterase. You're gonna have lots of acetylcholine, and then you're gonna have Dumbbell syndrome, diarrhea, urination, meiosis, and emesis. B for bradycardia, B for bronchuria, and L for lacrimation, S for salivation, right? So yeah. Okay, sorry, B for, I guess, bronchioconstriction. Okay. Lambert-Eaton myasthenic syndrome. I've told you about this. Polymyositis or dermatomyositis. It's an inflammatory myopathies, proximal muscle weakness, right? And dermatomyositis has skin findings, cotton papules. They are very common. They are asked on derma section of your step 1. Okay, so this is a structured review that provides your comprehensive and yet concise review of high yield neurology topics for your step 1 exam. And each segment is designed to reinforce key concepts, right? And to facilitate retention. Honestly, the main function, the main reason of designing such type of podcast for you from now on is that to reinforce retention, because many step 1 students contact me and they say that, oh my god, Daniel, there is too much information to retain. So me and the co-founder of this platform, Ritik Kiani, we have discussed these things together, and then we came up that we should make something that could help the students to retain the concepts, right? So trust me, if you see this video to the last, till the last, you're gonna remember these things for the rest of your life. Another important thing to tell you that this is something that no one is doing at this stage, right? That's why, and again, the important thing is that I am also a student, so I can understand the student better than anyone else. We are also student. Ritik Khan is also a student. So we both are students and we understand the demand of a student. So that's why I would strongly suggest you to listen to these podcasts regularly. Even if you are in the gym, if you are in somewhere else, just switch on the video and do your work and listen to these podcasts. These are very important, very highly for the step 1 exam. Trust me, they are designed to elevate your and boost your score. See you in the next video. Thank you so much for listening to me. This is Daniel Dask. See you in the next.